Buenas tardes, ahora sí, listos.
Good afternoon, and we are ready to get started. This will be the last session with presentations. And we have something that motivates us and inspires us for the end, which is the result of implementing Diabfrail in the countries. We will be listening to cases. We have 3 here, another 6 countries in the region. Now I will give the floor to Olga, who will be moderating the panel. Good afternoon, everyone, and thank you for being here for this last session of today's or of the whole meeting. We have extensively discussed management of diabetes in older people and also management of chronic diseases in general in older people. And we've talked about the good results we've found in validation and otherwise in the Diabfrail Latam project, something that involves all of us here. Let us not forget that the main objective of Diabfrail Latam was to scale up an intervention that had already been proven to be effective. And as I said, to scale it up to other areas, to other countries. And for this reason, our colleagues will explain, and Samid explained yesterday the strategy that had been developed to scale up Diabfrail Latam, and they will be telling us what they did on the field and what they continue to do. So first of all, we will have Nidia Cañas, who will be telling us about the experience in El Salvador. Nidia, and please keep the times assigned so that we don't take up so much time. Thank you. Good afternoon, everybody. It is a pleasure to be here with you. And I'd like to start by asking you, what are the most relevant conclusions that you're going to be taking with you to implement in our countries? That we have heard about education programs based on patients' needs, and we've heard this from experts. So how do we translate that into practice, especially in our countries where we have many family practitioners, general practitioners, and there is a significant gap with geriatrics or gerontology specialists. This program is taking place in La Paz, and this is La Palma, Cuna de La Paz, and this is the situation of adults, older adults. We have 14% aging. We have 885,684 older adults, and how the distribution is in the country. And we will focus on the northern part of the country where implementation started. We see there the number in green, 22,008. So where did we see the opportunity for Diabfrail? We have 3 strategic axes: exercise is medicine, non-communicable diseases, and El Salvador has launched HEARTS, the program that has been so successful, and also the program for older people. If our proposal is to approach exercise is medicine, well, why aren't physicians prescribing exercise for older people? How can we solve this problem? Because we don't see, and one of the reasons is because we don't see older people as a person that is able to make their own decisions. So on July 29th, we did the launch after having had discussions with PAHO at the headquarters and in um, the office in El Salvador, and with the help of Dr. Samir from Colombia, we gave training to explain what Diabfrail is. So people were shown and trained and taught about the strategy. So very few were aware of how important the Diabfrail was as an intervention for older people living with diabetes. We had La Palma and the San Ignacio uh, areas. We have rural areas, we have urban areas, but we also have large areas where, you know, you have to, that are quite remote. So there are big distances to cover. They had the inclusion criteria were someone over 60 years of age willing to complete the 16 weeks of intervention, that they had to be a commitment for a week, excuse me, for having weekly meetings. And so how did we start? And of course, they were supposed to have been diagnosed with diabetes and were older people living with diabetes. Here we have participants divided by sex, and most of them were female. They had comorbidities. They about almost all participants had diabetes plus hypertension, and they had other significant comorbidities such as renal failure. So living with diabetes mellitus, uh, we had 62% females and 50% of male patients. We had the evaluation was done of the SPPB, and we took a baseline with the SPPB. There were severe, moderate, and mild limitations on the SPPB. Once the multidisciplinary health staff was trained, we started with the measurements, as you can see here. What was the roadmap proposed to implement in places? We started with La Palma. We had a group of older people who were part of the preventive health program. And so we thought that would be the group for intervention. And we would have weekly meets that, and the meetings were at a time that was convenient for the older adults. So, well, how did we do? Uh, we explained what the physical exercise was all about. We explained the passports and how it was important to advance in each one of the passports. We had educational sessions. We had teaching cards, which were developed for our population, who are mostly low in education and have difficulty interpreting health directives. And also they also should all have a cell phone. And then here we have the flow chart online. So if we couldn't do it in person, we could do it virtually. And for the first assessment, the patient receives the wheel for exercise for that given week, and then you schedule the video call with the person. We have a health system, which is an integral system, and so part of the program for these patients, we scheduled the 30-minute team, and they received an explanation about generalities of diabetes, what the study was about, what the intervention was about, and the diseases that would be evaluated. And a video call would then made doubts were answered, and we checked whether the person was able to do the exercise, and we made sure that the person had watched the video, and then we would have positive feedback, and we would set date and time for the next meeting. Here is an example of the booklets that were prepared. We proposed those booklets from the Ministry of Health and the implementing group from La Palma, Chalatenango needed to learn this, and so that we had an organized intervention. This is an example of session number 7, managing hypoglycemia, and a series of interventions, because it would be important to emphasize education of older people, making sure that older people understand what you're explaining and the things, the changes they need to incorporate into their routine. Here, we had the different booklets explained. First started with general points about diabetes. We have the executor, the implementer there, and this was an important phase. Take that medical knowledge to the level of older people, making people engaged in their own condition. This is how they learn how to uh, do a healthy dish. So the nutritionist and the implementer would ask the older people, well, what do you need to buy at the grocery store? For example, vegetables, yogurt, and other healthy things according to the plan given by the nutritionist. Here we see the physical exercise sessions in person. Here, they were also shown how oral anti-diabetes drugs work, how insulin works, the risk of insulin, and the risks and benefits of other medications used for diabetes, such as Depformin and others. For example, how can they also manage insulin therapy? They would go to a workshop where they would learn how to manage insulin administration and also complications. It was important for them to learn to identify hypoglycemia. So they played lottery or bingo. This was diabetes bingo, where they would identify the most salient signs of hypoglycemia. And here we had a post evaluation after the intervention, and we see how people had felt about the intervention and had a very good high percentage of approval of the intervention. And here, this is the most remarkable thing for us. You can see on the left side of your screen, before the intervention, that was their passport classification. And after 5 weeks, uh, and then after 10 weeks post-intervention, how they were doing. So one of the participants migrated all the way to passport E, which is quite robust. And so they made progress as they met each one of the wheels of the diaphragm. So participants were able to participate on their cell phones. And here we see prevalence of chronic diseases. Here, follow up on video call, educational sessions on video, and the SBB administrations in person. These are the results of the virtual sessions. As you can see, it's important to see the progression. And here we see how we went even further. We, as part of the physical activity prescription, we have the physical activity module. And if you see at the bottom, you see Vivi-Frail Latam, it includes each one of the activities they had to carry out. After we started in La Palma, Chalantenango, we moved to another health unit, which is the one at San Ignacio, another community. Here you see the older adults who have attended these sessions. Most of them, again, are women. We see feminization of old age, and we see the week number 5 in San Ignacio, and we see that there was a strong start, and then they are all migrating to Passport D. Most of the older people who participated are women. They are living with diabetes and other comorbidities. It's important to bear in mind that older people need to become empowered and self-managing. If people, or if the doctor thinks the older people cannot manage their own disease, they won't think that they're able. But if you encourage them, if you empower them, they will be able to do it. And this is so. Older people with 3 comorbidities are, for example, with chronic renal failure, they used to think that sweating was a negative thing that could affect their hydration, especially because the family practitioner or the general practitioner would tell them, for example, oh no, don't drink more than X amount of water during the day. And they would be all concerned because if they would go over the amount of water that they're supposed to drink one day, then they were all concerned. And we see 32% of participants live with chronic renal disease, and some of them are on an earlier grade. All of the participants showed improvement. We see 7 people who started on Passport B, 4 improved to Passport C, and 3 to Passport D. Out of 12 who started on Passport C, 8 improved to Passport D, and 4 maintained that category. Out of 3 people starting on Passport D, none had any regression, and I think this is significant. The impact results for Diabfrail is the fact that we created a community. Do you think creating community can be measured? Yes, it can. Um, Older people community can be measured. So communities that were constantly in a state of resilience, well, we were able to see that among peers, older people can work better and cope and adapt to any health program that is proposed. Those who didn't attend the educational session, then he or she would have a peer that would ask, well, why didn't you go to the session? Also strengthening uh, other people or intergenerational people. But we believe that maintaining intergenerationality and the life course is important because we all go through the different stages. Older people have their rights. So making younger people aware of this is important. And we all work together as a team. They all are wonderful and they have done excellent work. The challenges and possible solutions, as I said before, if a person has no access to internet because they ran out of data, their data plan does not include it, then the session could be rescheduled for the same week if they had connectivity. The assigned health staff, if the implementer had some problem, then they all have the training so that someone could replace the person who was responsible for that care.
And if there was any concerns or questions that it could be dealt with online or another meeting could be rescheduled. And short-term goals to make videos and the wheel exercises with the implementing equipment, also to provide diplomas as an encouragement and incentive for older people that had completed the course, and obviously to escalate this to the national level. That's a major objective. Thank you. Thank you very much. Now I give the floor to Dr. Walter Sepulveda, who in addition to being one of the researchers, have been working on the validation aspect in Chile. Also, he's implementing this in other areas in Chile. Thank you so much, Dr. Olga. I'm very happy and thankful for this opportunity to be here. It is for me a dream as a professional to be here of the Pan American Health Organization, to be together presenting this to other experts. Very grateful about that. Also to mention that what I'm about to present are preliminary results. And it's very hard to summarize something that has taken a long time and to put it in 15 minutes. I will tell you about Chile, as you can see how diverse it is, the great diversity of landscapes that we have. Also, that's how diverse our population is. So many times, and here I would like to ask you to think about this, because each region has different characteristics. Each region has different psychosocial and geographical and social aspects that are important to consider, and that should be taken into account in the research. And it's important to think about this because when I decided to do the research in the Quinoa region, where the percentage of older so it's very similar to the region of Maule, where we already doing this too. Also, as I saw my colleague, he was talking about the people that are using internet and WhatsApp. I can tell you that these two regions have a 23%, or 2 out of 10 older people use internet. That was something, it would have been very impossible to do it as compared to Santiago. Also, we have different characteristics because in these regions, most of the older people live alone. And more than 50% of this population does not participate in any community or community organization, which we know is a protective factor. So how do we deal with that? So even though we're centralizing the research in the capital cities, and because that's where we have our research centers and laboratories, we're trying to do research where nobody has done any research before. And we have to study the characteristics because most of the researchers focus in Santiago. But here we have some numbers of publications that are coming out of Santiago. Look at the number of publications coming out of each region. That's why for 10 years, we had a first publication in Rengo, and then we realized that older people in rural areas were different or showed some differences. So here I would like to reflect on this, because to research and to be the voice of the problems that not everybody can see, and also deliver messages to those that cannot be heard. And that's why the researchers that go to those populations that have not been studied before, especially older people living in rural areas where the populations that do not receive much. And some of those populations are also, is one of the cities here. So perhaps because of the Ministry of Health, since it's not a capital city, small city, but for me, it presents an important vision for landscape, for the scaling up. So why not jump to a hybrid program? What does it mean? Does it have a certain rural population and a certain percentage of urban population? And as I mentioned, it's one of the cities that has a higher percentage of older population. So a challenge for us is how to do research in that area, because it's very far away from where I work, from the university where I have a team. So we have to go out there to hire the people and train people. That was so wonderful. But I'm going to show you, and it was thanks to that support to all of the health team in the city. And they saw it as a novelty. So perhaps when we go already with a study with Santiago, another city, they're already used to seeing that. It's incredible how the authorities and patients see this as something new, something that they didn't have before. And it's interesting to mention that because perhaps that explains also the high adherence to the program. Of course, we did very well in this community. Even if our research goal was 250, here we had higher. So there was a commitment also by the authorities and support by the health system, also access to clinical information. So also by transportation team, also they provided support because these were places that are hard to access and sometimes it's hard to conduct those programs outside because they're in a rural communities because they're far away and difficult of access. So it was important to have a community supporting that to do all of that. And as my colleague already mentioned, we did the design and educational program, and this is something that we have already discussed a lot. So I will just show you that we divided this in 5 phases. The first phase, which is the recruitment part with the support of both the local authorities and also the media. We were able to reach all the different people and also to have access through the media and also to be able to recruit 147 people. That is considered a large number for such a study. And then also in the 6 communities areas were divided in 6 different sectors. As you can see perhaps the distance from each center from one another. So it was far for us. There were 6 sectors, so we had to go by car. Let me tell you how the initial evaluation was. Initially, we have to develop the SPPB score, and you can see high percentage of those people in those 2 areas were very similar, characterized by the wheel A and wheel B. These are older people that even though they have high functionality, they have a high, do have high functionality. In addition here, we wanted to put together a club. So in addition to what PAHO gave us, so we decided we're going to evaluate how they're doing under pre-frail and frail. So we developed this diagram and then we could see the ones having a higher frailty. The category, it was 54% frail, 45% pre-frail, and 1% robust. And you can see how this is very interesting. Here, I would like to think about this and reflect on this. And the 5 criteria of frailty, you can see the 2 that are more prevalent in the older population living with diabetes. The one that can be seen here among women depends on the physical activity. And the other one, weakness, muscle weakness. Those are 2 criteria that can be modified, can be done through exercise program. And that's why it's good to see the effect of Diabfrail is good in prevalence, because this is something that we're also asking in the project. Well, if they're fragile, what are the criteria? What is it that we're going to modify? So those having a high prevalence, those factors can be modified through interventions. Also here, I would like to tell you that a large percentage of them, about 66% of older people received a passport D, 25% passport C, 7% passport B, and 2% a passport A. Now, regarding implementation phase of the program, it was a very good experience. We also had a great team of professionals who conducted several workshops, as the previous colleague said, by developing different topics. We completed 100% of the educational programs and 86% of the exercise program, and the adherence to the program was 73%. So that speaks about the fact that the program is well liked by the program and people are encouraged to participate. Here are some other activities that we carried out because everything is not science. We celebrated the holidays, the national holidays. So we had some meetings and parties. And I know that it doesn't look very healthy when we got together having those parties, but in the morning, we saw that it's very important to generate social involvement and participation because they create team effort, a team spirit. So that commitment, especially when once they're included in a group, is very important for them to be part of of an activity, promote social participation, which is very healthy for the older person. If they do not participate, if they don't adhere to the program, they will not achieve results. Then the following phase is the follow-up phase. 65% of the adults improved. 8% of them did not achieve any improvement. 70% remained the same. But I would like to tell you that 17% of those who remained the same were older people that had reached the ceiling of the SPPP, meaning that they could not improve anymore. But what could they improve? How they could improve in some other variables. And here we can see there's something where we can see some differences, significant differences. See what happens with time, the time that it takes for them to walk, gait speed, or the time that it takes for them to get up. So we can see improvements in the speed, which means that even though we might not be any improvements in the SPPB, the gait speed or the muscle strength, we do see improvements there. So, and we could corroborate that with the data from the research. So even though they might seem very similar initially, as seen as separate variables, when we look at gait speed and muscle strength, we saw that there were improvements. Regarding the reevaluation of the program, we haven't completed that yet. We're supposed to do it by December, but also I would like to let you know that there's some other results that are important to mention. Other results which are not really based on science or not really based on the research, but it is what the patients tell us. Many times you can report it. It's not going to be published in a paper, but it will be left in the memory of each one of us. And I would like to, when we have those, we have a video that I want to show you with the testimonies that people gave us. It's better for you to hear directly from what the people said. The support that the team has been giving us is wonderful. And we're hoping that they will continue to be with us when we need them. I'm very happy with this, and I would like this program to continue and not end, because we need it. We need them. We help each other. They have helped us a lot. We have learned a lot, and we want to stay with it. At least it has helped me a lot, and even lost a bit of weight. As a result, I have been improving step by step. We have learned to do exercises, to do all the exercises, and we're very happy. We have learned a lot about exercises that help us to live a better life. We're practically asleep before, physically speaking, but with this practice, it has given us life back. I feel very happy to have made that decision, because even though I have to travel, I don't want to miss any class. They're very interesting, very positive. And for me, who I live by myself because my children are far, so it has helped me a lot. It has lifted up my spirits. It has changed my life. It's like having gone back into my youth because of my age. I'm 83 years old. My children are very scared, are afraid that I travel by myself because I have to move from one side to another. But now I have become independent, and I felt the company supported by God and the support and affection of the group and of all the professional people. They are very wonderful people, and continue being that way. And may God bless you. So as you can see, a lot of things that go beyond the numbers. This is what the patients tell us. And as they say, they tell us that they hope that we can continue doing that. Thank you very much.
Muchas gracias. Pues ahora tiene.
Thank you very much. Now we give the floor to Aurelio Espinal to talk about his experience in Honduras. He will be speaking virtually. He's connected virtually. Good afternoon. First of all, I would like to know whether you can see my screen. Yes. Thank you very much, Doctor. Warm greetings from Honduras. Yes, I would like to tell you that the experience that we have been listening to throughout these 2 days is very encouraging. And this is something also the same thing we've been doing with the older adults in Honduras. We have been doing this for 2 years, and we're trying to see how we can implement, how we can adjust this to the decade of healthy aging, and what other modifications we can do. And it has been quite an experience to give that comprehensive and help to older adults. So we have decided to implement this experience interinstitutionally, involving the Secretariat of Health, also the Secretariat of Social Development, and also with the support of the United Nations Office. So we implemented in 2 different areas of Honduras, very high mountainous areas, Santa Barbara and in Tibuca, with the high percentage of indigenous populations living there. It's a very high altitude places with populations also having a lot of high indigenous populations, which was a challenge for us. So we were thinking about how are we going to work with those populations. And after we heard our colleagues from Chile, we also in Honduras, we have a multicultural population. We also have a very an important institutional work to be done in this area to see how we're going to approach this in a different way, dealing with different populations. So as a tool that we can implement from the institutional point of view, also from the civil society point of view, also from government perspective, even from a personal point of view, also motivated by the proper introduction of those programs. So we decided to go into a systematization program so that every area they can do it in an orderly fashion, and we can adjust it to the reality of each place. Now, what were the areas that were decided for the implementation? After looking at the experience of Salvador and Chile, we agree in a lot of aspects. First, we started out with the training of the professional staff that would provide the support of the development of program. We had the doctors involved, nutritionists, psychologists, nursing personnel, and other health personnel, and it was very, very nice. Even civil society, and also the institutions working to advocate for the elderly. Also, they provided, and also provided support for the programs. In the second stage, we did focal points with the participants, where the local governments, where this was going to be implemented, and then they were introduced through their own media in order to capture the programs that are to involve the participants, so and involve them in the community. And here I would like to add that Honduras is not ready to present any statistics or any data, because we're only at a first level of systematizing and compiling of data. But very soon we will have some hard data for evaluation. As for the evaluation of participants, we know that is very important because satisfaction by the participants is the leading factor in those programs. As a third aspect, also the assessment by the participant themselves, not only the but afterwards, and also by the PAHO participants that were provided support during the sessions to make sure that the use of the tools during the evaluation were properly utilized, and also to avoid any bias in the implementation of any of the passports. In just like in the cases of Salvador, also in here in Honduras, we have some special geriatrics or some doctors who are working in the area. So these programs can be implemented by any type of professional. So this has been very important for every practitioner to understand. After that, we went to implement the different passports and how to use them. Here we call them exercise booklets in order to provide the different tools, and also then to move on to the implementation of the exercise program, which by using the digital tools, which has been very helpful. And we have has made it possible for us to take it all the way to rural areas. And in fact, this is where we're at, where we just visited a few days ago. We did a middle term assessment where we have taken, they have acquired a lot of experience and knowledge because of all the opportunities that were provided. And also as far as the execution time, there are also some factors due to the aging, to the fact that just the aging factor makes it more difficult for them to implement it. So that's something that we have to deal with properly. So we're going to be completing this by the end of November, and in December we're going to be doing a final evaluation to collect the data on the implementation of the programs. And after that, we will do a survey to measure satisfaction and get some feedback that we will feedback into feedback from the participant. Now, how many participants? Initially, we had thought that in each municipality, we would have 10 people that were having diabetes, and then 20 without diabetes, and then each municipality, and totaling 40 people per municipality. So we have one in Santa Barbara. The experience was very positive because in the education, in the training workshop of facilitators, the health authorities on their own invited technical personnel from other locations so they could come here and see and replicate these programs in their own communities, and not only in how to obtain data, because we haven't focalized them or focused, but we do have to pay attention on how it's been taking place in other areas and how they are replicating this. So now, what is the dynamics of the facilitators? The facilitators, both in San Nicolas and in Santa Barbara, what they do is that they meet in San Nicolas in the House of Culture. As you can see above on the left side, this is a place which has been very beneficial for this kind of a session, in order to also promote intergenerational development, because the House of Culture, it's really devoted for the teaching of music to young people, but it also has been used for intergenerational activities. Also, there is another center, a health center, in the Salud del Llano de la Virgen in this municipality. So we use that space, or that facility was also used also to implement those programs there. Now, how is the dynamic? Well, the dynamic is that they meet at least once per week, both the Diabfrail groups, and so during that group, that meeting, they would listen to lectures on how to live health and how to lead a healthy life, and how to manage diabetes to live better. So also the people that were participating in Diabfrail, they also wanted to be part of these talks, also as well as the people with diabetes. So there was an added value in those activities. And the other exercises during the exercise wheel that were done at home during the weekends, but they were always done by providing additional support through health promoters during the different exercise cycle.
So what are the pillars of our program? In Honduras, we are used to working with a part and the counterpart. So we are receiving a technical advisory for older adults, and PAHO has already provided 4 workshops, 2 training workshops and 2 follow-up and learning how to use follow-up tools, and some testimonials have been gathered, which I hope can be shared at the end. They have helped us with written materials, both for the trainers and for the people. And they also have other things like the tools that are used and the little gifts, and like the hand towels or the different things that the people receive. The other counterpart that we have, in addition to PAHO, are the authorities. We have the municipal support at the mayor and others. So we have the people who work in healthcare. They are people who are out there in the community, and they work with great love. And we have nutritionists, psychologists, social workers, nurses, and even we have a musician, because we discussed with a teacher and we saw that the music program could be replicated with the people in the Diabfrail groups. So I am keeping time because I don't want to run over. In September and October, we had some follow-up visits, especially we wanted to include 3 components in our follow-up. First was to see how people were doing with their exercise routines, how people were feeling, what were their challenges, and also see people in their own environments on the field. Of course, we had a discussion with participants and facilitators, and we see pictures here. People were able to share their difficulties, their challenges, and what objectives they have met. So we had really wonderful testimonials from funny things that they shared, also surprising things, and also mental health and how it has been good for them. Their social health improves. Mental health was also helped. There was an older gentleman who had a suicide attempt, but the program has really helped him. So there was feedback during the visit, so that people would share and see what things could be improved. I know I have 30 seconds left. We have many challenges, but I would like to focus on the opportunities rather. The presence of health personnel and the fact that they provide social services has been wonderful. Social participation in the process by older adults has been wonderful. The fact that there are people there being supported by their churches, the councils of the cities, community leaders, all of this can help. And also the fact that there are different ways to train, and even as I mentioned, the music classes. So in places that are not very accessible, having this kind of work is a great alternative. And thank you very much. A big hug from me. And I am very happy to